You will find the Gracey 1516 Curette in the Advanced cassette. In the standard cassette, we have the Gracey 12, Gracey 1112, and Gracey 1314. The Gracey 1516 is a Model 5 version of Gracey 1112, and it was created for increased access to the mesial surfaces of posterior T. The Gracey 1516 Curette has a shank that bends similarly to Gracey 1314 with the blade offset to adapt to the mesial surface of posterior T. This instrument aids in better adaptation to the mesial surface of posterior T, reducing patients' tissue trauma and reducing clinicians' hand fatigue. The modified pen grasp. Hold the instrument by the handle using thumb and index finger with both fingers placed opposite of each other on the handle. Knuckles of the thumb and index finger should curve outwardly. Place the middle finger lightly on the upper portion of the shank. Use the ring finger to establish fulcrum. Adapt the toe mesially and make sure that the lower shank is parallel to the long axis of the two. You can use the V to the D technique where the V is highlighted in red and the D stands for the distal surface of the two. If the face of the instrument reflects light, then you are using the wrong end. Use intraoral fulcruming near the working surface on the same arch. Ring finger should be kept straight during fulcruming. Use the pad of the ring finger on a tooth near the tooth being instrumented and on the same arch. Correct placement of the finger rests will provide support for wrist motion and lateral pressure, as well as preventing patient and clinician injury during instrumentation. Advanced fulcrumings. The Chen cup extraoral technique for maxillary posterior T. Use the palm to cup the patient's chin for support. Cross-arch intraoral fulcruming is done by placing the ring finger on the tooth of the opposite side of the same arch. Opposite arch intraoral fulcruming is done by placing the ring finger on the tooth of the opposite side. Finger-on-finger fulcrum. The non-dominant index finger serves as a rest point for the dominant ring finger to rest on. The index finger on the non-dominant hand is positioned in the mucobuccal resting against the attached gingiva. Correctly utilized advanced fulcrumings such as cross-arch, opposite arch, and finger-on-finger fulcrums will increase accessibility on hard-to-reach areas while maintaining optimum parallelism of lower shank to the long axis of tooth surfaces. Position the instrument so that the toe of the working end is pointing towards the mesial surface, which is the get-ready zone, and then adapt the lower one-third of the cutting edge slightly distal to the distal line angle. Insert the blade into the gingival tissue with the face of the blade adapted to the tooth surface at 0-degree angulation. Slowly and gently slide the working end below the gingival margin to avoid gingival trauma. Move the handle up or down to establish a 70 to 80-degree angulation. Use wrist and forearm motion to activate exploratory and scaling strokes. Rotate your hand, wrist, and arm as a unit by pivoting on your ring finger. You can use turning a doorknob movement, throwing a frisbee movement, or painting a fence movement. Don't use finger pulling motion because fingers have smaller muscles and such motion will cause finger fatigue. Use horizontal, oblique, and vertical exploratory or scaling stroke. You want to activate horizontal stroke by lowering the instrument handle until the toe is pointed towards the sulcus of the pocket, and use very short and controlled horizontal strokes. Horizontal strokes are useful on all surfaces of the tooth, but especially useful in removing deposit around the line angle. Activate oblique strokes by positioning the toe in a coronal direction away from the sulcus and use very short and controlled strokes. Oblique strokes are useful on all surfaces, but especially useful in the facial and lingual surfaces of the posterior T. Activate vertical strokes by pulling the working end up vertically in a short and controlled motion. Vertical strokes are useful on all surfaces, but especially useful in the mesial and distal surface of the posterior teeth. Different strokes are performed according to the anatomy of the tooth. When you are ready to activate scaling stroke, lock the working end against the tooth surface and place it apical to the calculus deposit. This will ensure removal of calculus. Move the handle up or down to establish a 70 to 80 degree angulation. To remove calculus, apply lateral pressure onto the lower 1/3 of the cutting edge. You want to stabilize the fulcrum by locking the joint of the ring finger because it provides support for the hand during instrumentation. You want to firmly press the ring finger against the occlusal or the incisal surface, which provides control during instrumentation and prevent tissue trauma. Finally, you want to apply equal pressure on both index finger and thumb inwardly against the instrument handle in order to press the working end against the calculus deposit. When scaling towards the proximal surface, use the index finger and thumb to roll the handle to keep the tip adapted to the tooth. Scaling at least halfway across the proximal surface will remove the calculus deposit embedded deep in the proximal surface. This is an example of scaling for left-handed condition. Advanced root scaling. You want to treat each root surface as different tooth. For the distal root, begin at the distal line angle and scale using horizontal, oblique, or vertical stroke to debride the mesial surface of distal root. For the furcation area, use the toe of the instrument against the roof of the furcation. Use very light pulling motion of the toe. Too much force will damage the furcation area because it is not as strong as the enamel. For the mesial root, you want to begin at the mesial line angle and scale using vertical, horizontal, or oblique strokes to debride the mesial surface of the mesial root.